Hello, everyone. Welcome to today's session. My name is Erta Kalanji. I'm a researcher at CDEP, and I'll be moderating the webinar today. Today's session is the fourth one in a series on conversations on global health, which we launched to celebrate 10 years of CDEP. Today, we'll explore long-term effects of early nutrition. We'll touch upon health and non-health outcomes, as well as economic consequences. We'll also discuss some of the challenges with improving childhood nutrition across the world, especially and for this today, we are very happy to be joined by experts in the field that will share with us both research findings and their views on the topic. So here with us today, we have Dr. Jere Behrman, Professor of Sociology and Economics at the University of Pennsylvania. We have Dr. Maureen Black, Professor at the Department of Pediatrics at the University of Maryland. We have Purnima Menon, Senior Research Fellow at the International Food Policy Research Institute. And then we have Dr. Arindam Nandi, Senior Research Fellow at CDEP. We will have a discussion with the speakers, and then we'll have some time to take some of your questions. So please do submit your questions in the Q&A section in the chat. We are ready to open our session. Initially, Dr. Ramanan Lakshminarayan, Director of CDEP, was supposed to be here and give a brief presentation or a brief introduction to this topic. But he's not able to join us here today because he's leading campaign efforts on trying to raise funds trying to raise funds in order to help with the situation in India. As you all know, the situation has been dire all over the world, but recently it has become so much worse in India. So our colleagues at CDEP are working hands-on at the moment on trying to raise enough money to buy oxygen tanks and concentrators in order to help those that cannot afford it. So basically, the situation on the ground is that hospitals have reached their capacity, and doctors are telling people, are advising people to get treatment at home. But there's so many who cannot afford life-saving medical oxygen. And for this reason, the CDEP team, in collaboration with a lot of other team members and other organizations, has started this effort. So the campaign is called Oxygen for India. You can visit our website at oxygenforindia.org. And you can make donations through that website. You are also able to make donations through our own website at CDEP, so at cdep.org. Thank you. Thank you for listening. I took the opportunity to bring this to your attention, since this is something that is affecting all of us these days. And we are now ready to start our discussion on childhood nutrition. And I will start with we'll start with Dr. Jere first. So thank you very much for coming, for joining us today. Some of the things that we wanted to discuss are health and non-health outcomes related to childhood nutrition. So how does early childhood nutrition affect future health and non-health related outcomes? What are the main pathways governing it? And what do we know about the economic returns? Over to you, Jere. We're not able to hear you. But take your time and... Yeah, we can hear you now. Perfect.
Okay, thank you very much. I'm pleased to be here as part of the CDEP 10th anniversary celebration. Of course, very sorry given the current situation in India. The work on undernutrition, or particularly chronic undernutrition, tends to focus on stunting. And here's an example of two little girls in Peru. The shorter one actually is the older of the two, and she is stunted. The other one is of normal height. Stunting has a technical meaning of more than 2 standard deviations below the median of a well-nourished population. In a well-nourished population, there'll be some children who are stunted, about 2 or 3%. But if you look at the world as a whole, the amount of stunting is much greater than that. Down in this corner, it's about a quarter, 10 times as large. And it's particularly large in sub-Saharan Africa and South Asia. And in terms of just numbers of people, this means for children under 5, there's well over 60 million in sub-Saharan Africa, another over 60 million primarily in South Asia, and over 140 million children under 5 in the world who are stunted. This stunting occurs in substantial part very early in life. These are the months of life along the horizontal axis, and the blue line is the line of interest. This gives the average height for age Z-scores. In a well-nourished population, these would be at 0 along this horizontal line. But in poorly nourished populations, there's sharp declines over the first 24 months of life, and then it tends to sort of flatten out. This has important physiological considerations because this is a time of critical physiological growth. Also important neurological considerations because of important neurological changes that are occurring during this stage of life. This is a summary from a well-known article by leading nutrition group of nutritionists, Cesar Victoria being the lead author, from the Lancet, which gives the relationship between schooling attainment, adult height, labor income, and birth weight of offspring with a number of anthropometric measures early in life, and finds these significant associations. This is an example that Harold Alderman and I produced using the best data we could find, in which we tried to summarize the present discount value of moving a child out of low birth weight status in a low income country context to no longer in that status. And the points I want to make here are there's a number of outcomes over the life cycle. We include 7 of these outcomes. And secondly, that given the best available estimates we could find, the big gains are not early in life, not from, say, reduced neonatal care, but from productivity gains during adulthood. They account for the largest share of the gains. I'm going to spend the rest of my time talking about the Incap nutritional supplement trial, which is in Guatemala, occurred in 1969 to 1977. 2 villages were given Atoli, which is a high protein energy supplement. The other 2 were given Fresco, less nutritive, and in particular without protein. Supplements are available to all every day over that period of 8 years, and all children under 7 in 69 or who were born over the period of the study were enrolled. And you can see here, this is the height for age Z-score. Again, 0 would be what you would expect for a well-nourished population. This population is much below 0 from birth. declining to severe chronic malnutrition, less than -3 by 24 months, and leveling off a bit after that. This is the supplement delivery. It was all you could drink. This is the immediate result of this supplement. Atoli is the protein enriched supplement. Fresco, the alternative. This is the percent of children who are severely malnourished. This is a very malnourished population. Almost half the children were initially severely malnourished. For Fresco, that didn't change much, but for Atoli with the protein enhancement, that dropped considerably in the half over the time of the period. So there are a number of subsequent data rounds that I won't discuss. We basically look at the effects of the supplement by the following consideration. The supplements occurred from 1969 to 1977. Those who were completely exposed to the supplement were from 1969 to 1974. Others were either too old or too young. So basically, we compare complete exposure with lack of complete exposure for Atoli and for Fresco. And we get a number of impacts in terms of education for women, but for women only. Schooling improved by 1.2 grades. That's a very large increase. The average schooling for women in this population was something like 5 or 6 grades. For reading and cognition, for both men and women, there were increases of about a quarter standard deviation 35 years later in their scores. So there are persistent improvements in cognition. In regard to adult economic activity, the key point is the bottom line here. For men and for men only, wage rates increased by about 67 cents an hour, or about 0.45 standard deviation, which is a very large increase. We perceive it did not occur for women because of the nature of the occupational distribution by gender. For men and women, there were some effects in the long run. This bottom bullet point summarizes those. Some bad, increased fatness, blood pressure, and blood lipids. Some good, reduced post-challenge glucose, reduced odds of diabetes. Again, this is almost 50 years after the original intervention. For across generations, for women only, but not for men, there were significant effects with the children and the women increasing about 100 grams in birth weight, over a centimeter taller, larger head circumference. Here's the height for age Z-scored, red for Atoli, blue for Fresco. You see for different ages, the Atoli, the children of the Atoli mothers had better height for age Z-scored. Then all these estimates that I've summarized so far are the impact of the experiment itself, of the supplement. But we also looked at the impact of height for age Z-scored at age 24 months and at stunting at 24 months using instrumental variable estimates to control for endogeneity. And the bottom line is there's impacts on many dimensions of adult life or adolescent and adult life, improved education, labor market outcomes, reduced poverty, limited impact on health outcomes, improve marriage market outcomes, improve fertility outcomes. So these supplements had very widespread impacts. Now, at this point, and I'm about done, but to this point, we've talked only about sort of the benefits, but presumably what's of interest for policy are the benefits relative to the cost. So we've also done estimates of those. These are costs summarized in which vary depending upon the context and upon the intervention. And here are the benefit cost ratios estimated for a number of high prevalence countries, primarily in sub-Saharan Africa and South Asia. And we actually attempted to be conservative making these estimates. The benefit cost ratios, the lowest of these is 3.8 in the DRC, all the rest are over 10. They suggest if our estimates are at all credible, very large benefits relative to costs from improving macronutrition in these populations. Thank you very much.
Thank you, Jere. I just wanted to check with everyone. Can you hear me right now? You can hear me? Perfect. Okay. Thanks a lot. Thank you, Jere, for that. We're now going to direct a question to Dr. Maureen Black, and that's on nurturing care. So concerning nurturing care, how important is it for a society's long-term health and well-being? And do you think that we're investing enough? What would you consider as priorities for the next 30 years, especially in low and middle income countries? And you have prepared some slides, so that's great. Thank you.
Very nice. Thank you. Let me start by saying that our heart really goes out to the people of India and the terrible issues related to this virus. And what we know is that it increases the disparities, and those who have the most disparities are at the greatest risk. So our heart certainly goes out to the people of India. I will talk about nurturing care, and let me start by defining what nurturing care is. This was originally, the science behind nurturing care came from a series of papers that were published in the Lancet in 2016-17. And as you can see on the slide, the nurturing care includes 5 components. Nutrition, of course, is a key component in nurturing care. This means what children need, what all children need. So clearly they need adequate nutrition, healthy nutrition. And on the top, you can also see they need good health. These are critical aspects of children's growth and development. And then you'll see on the left in the red that they need opportunities for early learning. This often comes through play. And then over on the right in the medium blue, you'll see that they need responsive caregiving. That means someone who is loving and nurturing and listening to them and playing with them. And then on the bottom, you see security and safety. They need protection from infections, protection from violence, and the security of having a stable home, a stable place to live. This is what all children need to grow and to develop. So where does that come from? Where do children get this? Well, they get it from enabling environments. So the enabling environments, you can see the circle of nurturing care sitting inside these green concentric circles. So the first place that children get nurturing care is from their families, from their caregivers, from their homes. And so what that means is for children to be able to get these 5 components from their families, their families need support. Their families need to be able to provide these 5 components, so they need the support to do that. And that takes us to empowered communities that can support families and can enable families to provide this. And then that takes us to supportive services. So those are services for those who need additional assistance with nutrition or with health or with any of the other aspects. Those are a part of the enabling environment. And then that takes us to policies. These are child family-friendly policies that can provide universal care for children, can provide education, and can enable families and to provide support for their children. Now, the way nurturing care works is that you need all of them. They are interdependent and they work together. So if one of them is awry, if one of them is not working, then the system does not work well. As Jere showed you, when children are not growing well, when they're stunted, when their nutrition is poor, the rest of the system does not work well. So you need all of them. They're all critically important. There's not one that's more important than the other. We need them all. They all go together. So as the science behind this was developed and reported in the Lancet series, then the World Health Assembly adopted nurturing care in 2018, and WHO has really advanced nurturing care, and you can see many countries around the world have begun to have programs related to nurturing care. This is for children in the first 3 years of life. This is a formative time, and we've learned that what happens early in life stays with you, so that we better get it right. The building blocks will do better if they have nurturing care. So what's happened recently is that we have recognized that, yes, the first 3 years of life are critically important, but that nurturing care really operates from a life course perspective. That means that you can see what this diagram shows is you can see the 5 components of nurturing care, but then you see that really where they start is prior to conception. So they start with the health of the parents before conception occurs, and then it's the health and well-being and nutrition of the parents prior to conception, and then during the prenatal period, so during pregnancy, and then you see the infant and toddler, and then you see the preschooler and the middle childhood, and then up through adolescence, and then it goes back again. So that it's an intergenerational cycle that occurs. So yes, we need nurturing care during the first 3 years, but it's not one and done. One continues to need, our children continue to need all the components. They continue to need the nutrition, they continue to need the learning, the protection, the relationships. So those continue to be important. And you can see then the enabling environment that starts with families and extends to communities and services and policies. And then it goes beyond to the economic, the socio-political environment, and to climate. So this is a conceptualization that takes nurturing care and spreads it from preconception through adolescence. This is a recent paper. In fact, one of the authors of this paper was Dr. Behrman. So we're excited about talking about nurturing care in a broader perspective, starting early in life, but continuing through adolescence. So we think of childhood as a continuum rather than segments. Now I'm going to show you some examples of how nurturing care works. The first example is from India. This is a project that we did in collaboration with the National Institute of Nutrition in Hyderabad. The rates, as you well know, the rates of anemia and iron deficiency are very high in India and in many other low and middle income countries. So what we did is work with the Anganwadi centers. You in India have an amazing system of the Anganwadi centers throughout the country. Very, very impressive. So we worked with children who were ages 3 and 4. We enrolled Anganwadi centers, and half of them got micronutrients during the first bites of their midday meal. So that means when the midday meal was prepared, a small amount, the first bites that the children received either had micronutrients or had a placebo. You can see the picture of the children there. And the rest of the bites did not. So we made sure that the micronutrients went in the initial bites. That happened for 8 months. And then we looked at the children's rates of anemia and along with other micronutrients. And then we looked at the children's development, aspects of their neurocognitive development. And what we found is that the rates of anemia, starting at 47%, dropped to 10% among the children who received those first bites of micronutrients. That was in comparison to the children who received the placebo. Their rates of anemia dropped to 36%. So you can see the dramatic difference between those kids who got the micronutrients and those kids who did not. You can see it in ferritin, and you can see it in some of the other micronutrients as well. So this method of delivery is a relatively economical. The micronutrients are not expensive, but the delivery can be expensive. This way, working through the Anganwadi centers and having the teachers mix it in the midday meal was a relatively efficient way of providing the micronutrients. Well, that's fine. They got the micronutrients, but how about their learning? Did it have any impact on their learning? So we evaluated children before. We had a baseline and we had an end line. And this is just an example of, we found differences in 3 areas of learning. This is an example of the language scores. And it's particularly prominent in the lower quality Anganwadi centers. So you can see on the left and the drawing on the lower left that the children started off fairly similar, and the ones who got the micronutrients are the dark line on the top. The ones who got the placebo are the dotted line. So their language got actually, they did not gain language skills at the rate that the children who received the micronutrients did. That translates roughly to a difference of what would be the equivalent of about 6 IQ points. Language among young children, again, these are 3- and 4-year-old children, is a very important component of development that predicts to subsequent development in primary school, so academic achievement. So we were very pleased to find this. We found on language development and socio-emotional development, and also on an aspect of executive functioning. So the children's regulatory process is also improved. We were excited to be able to see that these micronutrients early on also impacted the children's learning. And now I want to show you a study that we recently did using data from 2 birth cohorts, one in Brazil and one in South Africa. So this is the conceptual model. We know that when children have early adversities, and this could be low birth weight, this could be mothers who are undernourished themselves or who are not well educated, then that places children at risk throughout life. so that the adversities are represented by the gray circle on the left. And then throughout life, we were looking into adolescence. So the pink on the right circle represents human capital. So human capital would be aspects of growth, aspects of intelligence, and of psychological functioning. So the question is that if you had a nurturing home environment, could you disrupt the association between adversities and low human capital? So could you alter that? So in this study, what happened is that there were home visits among the families when the children were preschoolers between 2 and 4. And during the home visits, they measured the responsive caregiving and measured the early learning. So that's the red box that you see. So that's measuring nurturing care in the home. So the question is, if you have a household where there is nurturing care in the home, then do you disrupt the association between adversities and human capital? Well, let's see. What the next slide shows is that in the box on the left with the red around it, these are households where the nurturance is low. So there's not a lot of learning, and there's not so much warmth and interaction. And the blue box represents children who do not have a lot of adversity. The red box, medium, and the green box represents children, this is all in this red square, who have a lot of adversity. So when the children were adolescents, we measured their IQ, and you can see that there's a clear linear trend, those in the low nurturance households. So those kids who had low adversity had higher IQ, and those kids who had high adversity had lower IQ, as you would expect. That's what we found. When you look at this square, the rectangle rather, on the right, the green one, you will see there's no difference in their IQ. It's not there. But we still had children who had low adversity early in life, medium adversity, and high adversity. So what happens, the way we would interpret this, is that the nurturing household was able to mitigate the relation between early adversity and children's IQ during adolescence. So we found that nurturing care not only promotes development, but it can overpower some of the adversity that you have early in life. So that was an exciting and interesting finding. So if we take these together, what do we learn? Well, we learned that economic growth requires adults who have high human capital. That means they have health, they have intelligence, they have psychological well-being, and they're able to handle the demands of the 21st, 22nd century. And in order to get there, we need healthy, well-educated, functioning children. We know that nutrition builds healthy bodies and healthy minds. We know that happens. But we also know that there are millions of children who are raised with multiple early adversities throughout the world. And we know that these adversities increase the risk of low human capital. So what have we learned? We've learned that nurturing care, and that includes nutrition and health and responsive caregiving and learning opportunities. We know that nurturing care can mitigate the negative consequences of adversities on human capital. So in other words, it can break that relation. So we know that nurturing care can build high human capital. So I thank you and look forward to the discussion.
Thank you. Thank you, Maureen, for this very, very lovely presentation. We had another small question for you, but I think you touched upon it. I just want to check if everybody can hear me well still. Yeah, okay. So you touched upon it with your presentation, but and you know, for the purpose of time, we would like to keep this short, but do you have any other comments on the intergenerational aspects of childhood nutrition? For example, parental health, schooling, and economic status related in association to childhood development?
Thank you. Yes, absolutely. If you look at the slide that we showed, looking at nurturing care, the life course perspective, you see that if you are investing in the health and development of adolescents, then not only is the adolescent functioning better, but that goes back and that the offspring of the adolescents then, of the when they become parents, are more likely to be of a healthy birth weight and healthy birth length, and not stressed or challenged during pregnancy. So certainly it makes sense to, that's why we have the life course aspect. It's not one period you invest there and then you're done, that there's a continuity to it. The continuity in education, it starts early, but you have to continue it.
Absolutely.
So I'll stop there. And
thank you. Yeah, thank you for emphasizing that. Thank you. That was a very nice illustration. Over to Arindam, Dr. Nandi. Okay. So at CDEP, we've done a lot of work on the long-term benefits of early life nutrition in India. Could you please share some of the findings?
Can you see my screen?
Yes, we can.
Okay. Okay, great. So first of all, thank you for having me here, and thanks to all the panelists for joining us today. I'm going to jump right into the work that we have done based on the ICDS program in India, and Maureen talked about it a little bit. It's one of the largest nutrition programs in the world, focusing on early childhood within the first 6 years of life, where children, you know, this is a program which is across the board in India, and children are given supplementary nutrition either to take home or at the center. And there's also several other components of the program, starting from vaccination and health checkup and referral and nutrition education for the mothers as well. So this is a program at the community level, which is run by Anganwadi centers. There's one center in each village, and it has over 100 million beneficiaries, nutrition beneficiaries, and over 35 million preschool education beneficiaries. It's a very large program with about $3 billion budget last year, and recently it was combined with 3 other programs to make it a package of childhood nutrition and health program for children and nursing women and adolescent girls as well. So the bulk of our work is based on this nutrition trial, which was done as a part of ICDS back in 1987 to 1990. Now near Hyderabad in India, there were 29 villages, and of them, 15 were included in the intervention village, where the ICDS program, along with the food supplementation, which is daily cooked meal for pregnant and nursing women and young children, was introduced for 3 years. And after the end of the trial study over the 3 years, another 14 control villages were then introduced into the program. Now, this program gave a daily cooked meal, which had about 500 calories and 20 to 25 grams of protein for women, and about half that amount to children. And in the intervention and the control groups, there were similar levels of healthcare access and public health programs at the beginning of the trial. And back then, the main objective of the trial study was to assess the impact of this food supplementation in utero and in early childhood on the birth weight of infants. This is a quick map showing where the study was. Roughly these are the locations of the villages. This is interesting. So then the study was followed up several times. First in 2003 to 2005, this is Sanjay Kinra and his collaborators. Sanjay Kinra, who is based at the London School of Hygiene and Tropical Medicine. Him and his collaborators, they went to the villages in that time, and then they followed up the women who participated in this trial originally, and then they tracked their children who were born during the trial period of 1987 to 1990, and they were alive at the time of the follow-up. And then they invited, they set up a clinic in these villages, and then they invited the mother and the children, the mothers and the children, to participate in the follow-up study. Some of them participated in that round, and there was two other follow-ups. 2009-10 was one, and the last one was 2010 to 2012, and they collected a lot of data on these families. It was the main focus of the follow-up was collecting a lot of data on general health and a set of biomarkers, and the objective of the studies were to look at, for example, growth of children and cardiovascular outcomes and so on. So that was a primary focus of the study. Now later, so this study, the combined trial and all the follow-up rounds is known as the AP CAPS, Andhra Pradesh Children and Parents Study. Now we collaborated with them recently over the last 4 or 5 years. This is joint work with Sanjay and Jere and Maureen as well in some of these papers. So what we did is we went beyond, so by this time, 2016, when we published our first paper, the AP CAPS researchers had published a lot of work on looking at health outcomes. So essentially linking, the nutrition trial and the food supplementation with, long-term health outcomes of adolescents and children. So we went beyond health outcomes and we started analyzing, so they didn't have a lot of data on cognitive outcomes, unlike other studies, but very rich data set on, schooling outcomes, school enrollment, grades, and so on. So the first paper that we published in 2016 was using the 2003 round of the AP CAPS, where children who were born originally during the trial, at this point, they were 13 to 18 years old. And we found using regression and matching, propensity score matching methods, that children who were born during the trial in the intervention villages and were exposed or received the nutrition in utero or during the first 3 years of life, those children, now adolescents, they had higher enrollments, school enrollment rates, and also they had about 1 additional schooling grades. Although we did not find any difference in test scores in school, not standardized test scores, but test scores at school. Then again, we did another follow-up study in 2018 where we took the next round of the follow-up data when these children who were born back then, they were now 20 to 25 years old. And we again found that remarkably, the schooling benefits persisted in adulthood as well. So we found that they had higher completion rates of secondary and graduate level schooling. And then especially for women, 6% fewer women were married in the intervention group as compared with the control group. And in the overall sample, 5% higher employment or higher education rates in the intervention group as compared with the control group. Then 2 other follow-up studies. The third follow-up study we did was again using the same data set. We looked at the reproductive outcomes of women and men as well. And we found that, later menarche and later cohabitation for women with their partners, and it also delayed pregnancy. Women who were born in intervention villages, the first pregnancy was about half a year later as compared with women born in the control group. We did not find any significant differences between the control and the intervention group in terms of the number of children they had at this point. So these 3 studies were based on the trial data and the follow-up, but then we also went beyond that and we used a nationally representative survey, and this is the 4th study that I'm going to talk about. So we used, National Family Health Survey, which is the standard DHA survey done in 2005-6 in India, and we were able to track all the adults in the survey, adults, and I mean in the age group of 15 to 59, and we had data on their grades of schooling. And then we also had data on whether they were living since their birth in a village with an ICDS center. So there was a question whether the village had an ICDS center, yes, no. And if the answer was yes, we also, there was also data on the year of establishment of the ICDS center. So we matched this year of establishment with the birth year of the adults. And then we compared adults who were living during the first 3 years of life in a village with an ICDS center with other adults who did not have an ICDS center in their village during the first 3 years of life. And we find that adults who were exposed or who had an ICDS center in their village during the early years of life, they had higher schooling grade attainment as compared with adults who did not have a center or who had a center which was established later after the first 3 years of life. So these are the main studies that we have done, all related to the ICDS. There's another study, the 5th one, which is slightly different, does not look at ICDS nutrition, but it looks at breastfeeding duration. There also we used longitudinal data from APCAPS and the India Human Development Survey. And we had information on the breastfeeding duration for children from their mothers in the first round of the survey of these longitudinal panel surveys. And in the second round, we had data on their test scores and schooling grades and school enrollment. Using these 2 data sets, we found that longer duration was linked with higher test scores in APCAPS and similarly in IHD, the India Human Development Survey, which is the nationally representative survey. We found that longer duration breastfeeding was linked with additional schooling grades as well. So that's the bulk of the work we have done. And this is, the last one is to sort of a follow-up of what Jere has previously touched upon. This is another study with, Jere, I, and others wrote. We found that benefits cost ratios were really high of early childhood nutritional investments in low and middle income countries. So that's a quick summary of the nutrition work we have done, focusing mostly on the ICDS program in India. I'll stop there.
Thank you, Dr. Nandi. All right. Thank you very much for giving this, this very nice summary of very important work. I'm now going to direct my questions to Dr. Menon, Dr. Purnima Menon. So the question is on challenges related to childhood nutrition policies in low and middle income countries. Do you see any success stories? And for the countries that have struggled making improvements, what are the lessons to be learned?
Thanks so much for that. So I didn't prepare slides because I thought this was a panel and we were going to talk. So let me just firstly say congratulations to CDEP. It's been really nice to to see your work evolving on nutrition. And Arindam, I thought that was a great summary and some really important pieces of work there on nutrition. So I really look forward to seeing more of that. Second, I think what was so nice for me about, both Jere, what you presented, and Maureen, what you presented, which were really reflecting on the, the impacts of interventions and carefully done interventions on change over time, and then that dovetailing, Arindam, with your work on interventions and programs, and then to the national surveys, is that I think, we're at a point now where we have a lot of evidence from the intervention literature on the kinds of interventions that work. But what's been, for me, sort of a very rewarding piece of research that we've been doing, both at IFPRI and with a broader network of researchers under the Exemplars in Global Health team is, and I'll drop that in the chat box, a couple of links there for people to go take a look, is that we are now seeing sort of a body of real world, large scale change, kind of studies of large scale change at the national and subnational level in many different countries. And we've had the privilege of actually bringing that together in the most recent Lancet Nutrition series, which just came out in February 2021. And before this meeting ends, I'll drop a link to that in the chat as well for everyone. I think what's so clear in the success cases that we've seen, and actually I'll just focus my comments on that, is firstly that we've seen that success is possible. So in the Lancet Nutrition series, for example, we summarized about 20 national or subnational success cases, and 4 of the subnational success cases we showcased on reducing stunting are from Indian states, just to sort of make a nod to that. But the other thing that is very remarkable about the success stories is I think it maps phenomenally well to what Maureen, you were talking about in terms of the the vulnerabilities, but also in a sense what I think really comes out for me in the nurturing care framework is how important it is to have actions in many different sectors, and I think so the line that I'm using now around that is you can't solve nutrition or the challenge of nutrition with just a nutrition program. I think if we go into the nurturing care framework, if we look at the success cases that have been analyzed very thoroughly actually between the research team and network link to IFPRI's stories of change and the exemplars in global health that we summarized in the Lancet, it's so clear that we need to change the vulnerabilities. We need to change the household, societal, and familial vulnerabilities that put people in conditions where they're not able to provide the kind of nurturing and nutrition care that we want for their families. But I think what we've also seen is that change is possible, and that change is possible at scale. So the countries that we have, documented and seen changes for are, in addition to the 4 states that I mentioned for India, we've seen documented successes in Peru, Senegal, Nepal, Bangladesh, Ethiopia, even, and none of these are small, just small, tiny countries. These are countries where change has happened at pretty substantial scale. And it's now, in a sense, it's incumbent upon those of us who work in the sector to really move home this message that you need action in multiple sectors to create these nurturing environments. So let me stop there on, where have we seen success? The question of where have we seen failure, or what are we concerned about on the failure side, is, very much that, in big countries like India, the big states, the biggest states that carry, in a sense, very large birth cohorts. So the states of, Uttar Pradesh, Maharashtra, Bihar, Madhya Pradesh, these are states where, change has been slow, even in the previous decade in which we studied success cases. But more importantly, these are states that are going to be affected in very difficult ways, even as we look forward, in terms of the impacts of the pandemic and what that's doing. I mean, UP, for example, Uttar Pradesh has a birth cohort of 5 million a year. a birth cohort of 5 million a year, right? I mean, that means that if 50% of those 5 million births missed antenatal care visits, just, that's 2.5 million kids whose mothers didn't get the care they needed. So I think, for me, as I look forward, I feel like all our attention, or a lot of our attention, has to go to those places in low and middle income countries where most children are being born. We have to turn our attention to, states and countries with sort of high burden and high numbers, if we want to see the numbers change in the world. So I'll stop there. I'll drop a few of those links, and I hope that, what I tried to do here was to connect the dots across what, each of you had shared so eloquently about the findings from individual research studies, and then, some of the large scale research studies and the frameworks that we have to kind of look at the challenges that lie ahead and the successes. So thank you for that. I can see questions are starting to come in the chat box as well.
Yeah, thank you very much, Dr. Menon, for tying up, bringing together all the presentations and the discussions today. Some very interesting points, especially the question on how COVID, the pandemic may have affected everything today in relation to childhood nutrition. We are going to just look at some questions from the audience. There's one in particular, it's open to Dr. Black, but also others. And it's with regards, first of all, thank you for your presentations. The audience is very glad to have you here today. The question is on if you would have any comments on the ethics around the randomized controlled trials in nutrition research, and especially in low and middle income countries, where, for example, giving some children micronutrients while others receive placebo might be a problem, since it is known their benefits are expected or known.
Thank you for the question. The ethics of doing these studies is always of paramount concern. That particular study that was done in collaboration with NIN, we had to go through the ethical approval in both in India and in the US. It was a collaborative study. When we designed these, the children were certainly we went in an area and used what the children were already receiving. There, if you think about the micronutrients, it's not obvious that there's always a benefit. And in fact, one of the things we were concerned about would be the consequences. That could there be negative consequences? So we instituted a surveillance system. It was also completely double blind, meaning we did not know, the teachers did not know, the packages were that looked exactly the same. So it was totally double blind by preschool. And then I think it was important to say we instituted a surveillance system. So that meant that there were visitors to the households monthly that asked about diarrhea and respiratory infections and any other concerns. Which fortunately we did not find. But certainly the care and well-being of the children are paramount. The issue is if you don't do this, then you don't really know, you don't have evidence, and you don't know how much has there been an improvement or not. So we try to be we work with partners, as researchers typically do, so that we're all in this together. But I applaud your question on the ethics, and it's something that we should continue to think about and to be concerned about as we move forward.
Thank you very much for that answer. There's another question that may also be directed to you, because it's on maternal mental health and how that could impact nurturing care.
Thank you also for that question. There's no question that maternal mental health is really a very, very critical issue. and both in terms of the biochemical aspect of it. So that's what I call card-carrying mental depression, but also the millions of women and fathers and men who have mild levels of depression. So it's not enough to carry a strong diagnosis, but also symptoms, because they can interfere with caregiving. So yes, this is a concern. And what we do about it is look to, there are services that have been instituted by community health workers, some that have been published that can be effective. So maternal mental health certainly is an issue, and one that we should not ignore. On my slide of early adversities, maternal mental health is in there as well. So thank you again. It's an important issue. We should.
Thank you very much. I see that we have reached our, thank you first of all to all of you for your presentations, for the links. Thank you for showing up today. These are really hectic times. I see that we've reached our time has come to an end. We've reached the time limit for the webinar. And so I'd like to say thank you to everybody who participated. And I'd like to also say that our next webinar in the series is going to be on antimicrobial resistance, another important topic that CDEP is involved in, but this time from the One Health perspective. So thank you again, and I hope you've had the chance to visit oxygenforindia.org and be aware of the campaigns and the effort that is ongoing to be able to help as much as possible people who are in a great need at the moment. So thank you very much and have a good day, everybody.
Thank you.
Thank you. Thanks.